Well, welcome everybody. My name is Jake Timothy. I'm a spinal neurosurgeon in Leeds in the UK. And welcome to this very first European peer insight series on X360. And you're probably wondering what X360 is. Well, X360 is a new concept where you can do anterior, lateral and percutaneous screws all in a lateral decubitus position. We're very excited about this. We have 6 episodes, each covering a specific component on X360. Today, we're going to be discussing the actual concept of X360 and speak with 2 experienced surgeons who've adopted this technique in their clinical practice. And I'd like to introduce David van Schaik, who is a real European orthopedic spine surgeon. He's a Dutch guy, he works in Belgium, he likes to live around in the outdoors. He drives a British Land Rover and has a German Shepherd dog. So David, welcome. And also like to invite another friend, Navin Verghese, who is an excellent surgeon who's been using some of these concepts of X360 for some time, in fact. And Navin is an excellent drummer as well as an excellent surgeon. And some people say his drumming is better than his surgery, but that's for you to decide at the end of this seminar. So my first question to you, David, what does X360 mean to you?
Thanks for the first question. X360 means for me it's a lateral single position surgery where I can combine the anterior approach, the lateral and the posterior. And in this way I can combine the best of the two to get a much better outcome. And it was very new and demanding in the first cases, but when you get used to it, and when you get used to the position of the patient on the table, in a way it's also easier to do, because in the lateral position for the ALIF, the retroperitoneal content, it falls out of the way instead of on the disc space. So you get a better view on the disc space L5-S1.
Thank you, David. And that's interesting you mentioned that's easier to do the disc preparation and the expansion of the disc space in the lateral position. And I think we're going to hear in different series the advantages of doing this in terms of disc space presentation. We have one of the series, we have Gerby Borden, who's going to be talking about the X-ALIF, for example. Navin, I mentioned that this is a new concept. Is it a new concept? I know you're quite experienced in some of this, and I've seen some of your cases, which look fantastic. But tell me about what X360 means to you.
Yeah, thanks, Jake, for the kind introduction. As you alluded to, X360 is a company term, it's a contemporary term, which has been coined over the past year or so by Navin. But it's a philosophy which I've been trying to adopt in my practice for about the past 7 or 8 years. I've been trying to combine a technique which gives you good indirect decompression combined with restoration of sagittal balance, but at the same time in a minimally invasive way. The downside of the TLIF, which is another way of doing a 360 fusion in a single position, is that it does cause a lot of back pain. It is more of a maximally invasive surgery. So the reason I adopted this X360 type philosophy was to negate the pit sides and downfalls of TLIF surgery.
Thanks, Nav. You're much braver than I am, because I worry about whether you can get adequate decompression in these cases, in these X360s, when you do it all in one position and put the screws in. Are you really getting adequate decompressions? I worry that they might still have some sciatica following the procedure because I've just put the screws and haven't done open decompression.
No, that's a fantastic point, and that was one of my anxieties. It's a lot of people's anxieties when they start off on this journey of not so much just X360s, but the journey of the indirect decompression philosophy. But you'll hear me repeat this quite a lot, I'm sure, over the next 20-30 minutes. It's all about preoperative planning and patient selection. Earlier on in my learning curve, and a lot of people that can conceptually understand, the first patients you choose are those with foraminal collapse and foraminal stenosis. You jack them open with a big cage, lock them off without having to do an open decompression. Those patients get better. There's no doubt about it. And they, in my opinion and experience, they get better with without having to expose the dura and so forth. However, lateral recess stenosis, central stenosis, they are bits which you then add to your learning curve with the pacing selection. And there are certain nuances to the scan: lax ligamentum flavum, collapsed discs, listhesis, all these factors you'll be looking for to try and achieve the indirect decompression, which then will equal a happier and better patient.
Okay, Nav, I'm still not 100% convinced, and certainly in my practice at the moment, I do it in 2 stages. So I will do the anterior, whether it's an A-lift or an X-lift, and then I'll wake the patient up and I'll see if their sciatica has gone. Now, if it's gone, then I can just do a percutaneous fixation. If it hasn't gone, I'll then do an open fixation and open decompression. But, I'm still learning and listening to experience of surgeons around the world who are saying, actually, you don't have to do it in 2 stages. David, what do you think? Do you think you should do it in 2 stages? Is there advantage of doing it in 2 stages? Or is the X360 concept, doing it all in 1 stage, the way forward?
The concept is indeed doing it all at once, but before you start doing the surgery, you must think it over and again, that you really can get a full indirect or direct decompression. And I think when you are convinced that you can put in a big cage, if you can release the posterior ligament, if you can restore the height in the lordosis, then you really can do it all at once. The only reason sometimes not to do it for some colleagues or for the hospital is because of the reimbursement. But I'm very happy in Belgium, probably that will change as well. So we do not get more or less if you do it in 2 or 1 stage. Because I think at the end it's the patient who should get better. And if you can do it in 1 surgery, it's always better than in 2 if you stay in a normal operating time. So not an operation of 6 hours, but 3.
Yeah, I guess I've seen the videos in the US, and you have 2 surgeons operating at the same time. You have a vascular surgeon, you have the access surgeon, then you have the spinal surgeon. Nav, do you do your own access? Do you have a vascular surgeon? Have you found that it's been useful to this technique if you have 2 surgeons or not?
I personally, working in the UK, don't have an access surgeon. It's not a standard practice as it is in some countries such as the US. But there are benefits of having 2 surgeons with an X360. For example, with a spondylolisthesis, you can put your percutaneous screws in a single stage in a lateral position. You can also then do the X-A-lift approach. And as one surgeon is, for example, is implanting the A-lift cage, the other spinal surgeon, I'm talking 2 spinal surgeons now, by the way, but you can have 2 spinal surgeons implanting at the same time. So as the A-lift cage goes in, the other spinal surgeon, your assistant, your registrar or fellow, can then be reducing on the screws at the same time. And you get a fantastic and powerful reduction with that technique.
All right, guys, thanks for that. They're both good pearls of wisdom. Now tell me, it all sounds great. However, has it really made an impact on the recovery of your patients and the outcome of your patients, which is really why we try to adopt these new techniques in our practice? David?
Yes, about the impact, I can say when I was learning and doing and get much more involved with the X-lift, I really saw that the patients get much faster, better. They can get out of the bed the same day. They have not so much pain. I can put in a big implant, get a large stability. And I was looking for something to do it on the L5S1 as well. And that's how I find out it's possible. People do it. And that's how I met you guys and how you convinced me how to do it. And I get more and more experienced in doing the surgery in the lateral position. And my experience is we get a very nice control over the L5S1 and a very good control over the repositioning of the L5 over the S1 with the combination of the cage, the release and the screws from the back.
Okay, Navin, tell me, you've been obviously doing the most traditional approaches for some time, and you've now changed and you have really encompassed this X360 concept. Tell me how it's changed your patients' outcomes.
Yeah, that's a good question. It all depends on what part of my practice you're talking about. So the single level surgeries, which I alluded to earlier, I've replaced on the whole the T-lift technique with an A-lift or an X-lift plus percutaneous screws. In those patients, absolutely no doubt, it's a quicker rehab, far less pain, and they get home a lot sooner. Obviously, the longer term, so in the medium term follow-up, should I say, I've been doing, there's certainly a lot more lordosis, and hopefully by achieving the correct sagittal shape and balance of these patients, longer term, they will have better outcomes. Although, admittedly, it is too early to say that in my specific cohort. I've been doing the X360 for. In the other element of my practice, the more complex degenerative scoliosis patients, rather than being in 1, 2, 3 weeks waiting for the A-lift, the X-lifts, the posterior screws, I can minimise that. You cannot do a T10 to pelvis or a T2 to pelvis in one sitting. It'd be very bold and foolish of me to say that. But with the X360 techniques, you can minimise that down. So one day you'll do the anterior cages and the X-lifts. The next, 5 days later or so, you'll then put the screws in. And there's no doubt, in my opinion, with those techniques, the patients do have better outcomes, and it's certainly a better recovery.
Okay, Nav, thanks for that. Another question for you, and this is a common question that we are asked on the cadaver training courses. If you were going to do an A-lift and an X-lift at the same time, which would you do first? Would you do the X-lift first, or would you do the A-lift first?
Yeah, you're quite right. I've had this question on a number of the courses I've trained on, and I've got two polar answers. If you're early on in your learning curve and the preoperative planning says that you can access the 4-5 disc, for example, then what I would tend to do is do the X-lift approach first, because early on in your learning curve, the alien thing to you is the A-lift approach. So you can do your X-lift approach, you develop your retroperitoneal plane, and using that plane, you can then match that plane up to your incision for the X360, the X-A-lift, I apologize. However, there are certain nuances to that. If with your preoperative planning you've identified it's a very low 4-5 disc in the pelvis, which wouldn't be achievable normally with a standalone X-lift, you can get around that. If you do your X-A-lift first, if you put a big cage in, which always we're trying to achieve, and really jack open that disc height, you will then introduce the 4-5 cage into a viable target angle, and you'll then be able to achieve your X-lift. So the short answer to that would be A-lift first and then the X-lift in that specific scenario.
And that makes sense. I guess it's like building or reconstructing a house. You want a really good foundation. And the other advantage of doing the A-lift first, in my opinion, is that you can dial in quite a lot of lordosis, which means you might not need as much lordosis on the L4-5 level. But no, so the point is, do your A-lift first and then do your X-lift. Again, you guys are convincing me a little bit more about trying to change this whole concept of doing everything in one go. But like any new technique that you introduce, there's always going to be a learning curve. And my worry, like other surgeons who are listening to this, will be worried about introducing new complications. So David, tell me about your learning curve with this and any potential complications you've had and how you've tried to stop those complications by creeping into your practice.
Yeah, Jake, thanks for the question and the good point about the learning curve. For me personally, the implementing of the posterior mid-screw was the most challenging part. It was very difficult for me. And one of the key points, I think, is the positioning of the patient on the table. You really have to think it over and over before you start doing the surgery. And like in a classical open posterior procedure, you still can feel the bone, you can feel the bony contours, so you know where you have to go. That's one of the important things. And I realized after, I think, the 5th case, it really got much better, and the time I had to use for the posterior screws, it really dropped. Another very important thing is how we organize the operation, that everybody knows what I'm doing, that they can also help me or attend me, that I have to change something. And those things together really reduced my stress for putting in the screws and really improved the outcome for the patient.
Thanks, David. Nav, I'm going to ask you the same question again. You've been doing this for a while. Has your setup changed since you first started doing the X360 maybe a couple of years ago or a year ago to what it's like now?
Yeah, I mean, that's a great question. There's another question which I get quite a lot from learners when I'm on faculty. It is the key to X360 is about the procedure, is about the flow, how you set up your theatre and so forth. But again, I will continually remind you, it is about the preoperative planning. And the key is, do not let a patient enter that theatre for an X360 unless you've planned and deemed them appropriate for that. What do I mean by that? For example, if you're going to be doing an X-ALIF and you're planning on doing percutaneous screws, you have to compromise the position where the patient is on the table. You want them a little bit further back than you feel comfortable with the X-ALIF. However, if the patient has a lot of posterior adipose and it's a long way from the skin to the pedicle, then the downside screws are going to be at a very difficult angle no matter where you put them on the table. And so in those patients, I wouldn't consider a single position surgery or X360 for those. So that's the main nuance in terms of the pre-op planning.
Do you have a special table now? Because when I tried to do the X360, for the ALIF, I've got to put the patient very close to the front end of the table, and then for the screws, there's a big gap, and that. So, do you have a special table that you use that makes it easier for you?
No, it's the same measurement table I've been using for years for X-lifts, because you can break the table when you're doing the X-lift part, you can rotate the table when you get in the pedicles and the true AP. But as I said, you need about I would say between the skin and the posterior edge of the table, about 2 to 3 inches. As long as you've got that, then you should be fine. If it's any more than that, then you're in a bit of trouble.
And I think you're right. You know, the position is really, really important. It's probably one of the most important parts of taking this on, how to position the patient. And complication-wise, are you worried about complications because it's a new concept? Are you seeing complications? Of course, I've heard you never get a complication now, but are you seeing any? And if so, how are you dealing with them?
Well, again, what is key, worries everyone in terms of the X-ALIF part of the X360 in particular is vascular complications. That's what everyone's frightened about, and understandably so. But again, I don't want to sound like a broken record, but it is about preoperative planning. You want to make sure that you have a good path to the 5-1 disc. Bear in mind the X-ALIF is purely designed for the 5-1 disc. You don't want to be tackling ones where the vessels are in the midline, and there is a nuance to this between planning between supine and X-ALIF techniques. You have to bear in mind when the patient is in a lateral position, the veins in particular can drop. It may only be 2, 3, 4 millimeters, but they can drop with gravity, and you have to factor that into your planning. So you have to have a bit of perspective thinking with that. I've been trying to adopt in my practice now lateral decubitus MRI scans for patients I'm working on for X-ALIF. Hopefully I'll be publishing that in the next year or so. But we are finding, it is subtle, but we are finding subtle millimetre by millimetre changes in the lateral position, which helps them which approach we go, either via left or right for the X-ALIF.
That'd be very interesting if you get that published, Nav. Very interesting. And talking about broken records, I heard that's what people do when they listen to your music. They break a lot of your records.
Yeah, well, that's because you're playing guitar, Jake.
True. Okay, so we've all been on training courses. We teach on them, and people who are interested in listening to this webinar might say, "Well, how do I get started with this new concept?" David, have you got any tips of how, if a colleague of yours in Belgium says, "I want to start doing X360," what would you tell them?
Well, the interesting thing first would be the question, do you do X-LIF? Do you do A-lifts? Do you already put in percutaneous screws? Because that will really help. If you don't do it, you can still learn it, but it will take a little bit more time and energy. And I think for learning a new technique, I always use the same steps. I first go and visit a surgeon who can do it very well, who is very experienced, and even more important, can teach it, can tell you all the tips and tricks. First step. Second step, I would go to a course where you can practice it on a cadaver with people who can really teach you, and where you can do all the mistakes and all the things you cannot do on a normal living human being. And third, at home, I would practice with my OR team on a cadaver in our own hospital, and where we can really practice our own hospital flow. what I have to do, what they have to do, and what we expect from each other to do. That will really help and really get us all at ease. And then when you finally start preparing your first case, I think it's very wise to discuss it before you do it with a colleague. He can discuss with you about the indication, because that's the most important thing in spine surgery, indication. He can already tell you, watch out for this, will you do if this will go wrong, so your plan A, B and C. And after the operation, it's wise to discuss it with the same or with another colleague. And you can discuss, how did I do it? What can I learn from my mistakes? What can I do better? And I think when you follow all those steps and really involve your OR team, you can really get a much better and efficient OR flow and do a better operation with a better outcome, because that's what counts most.
I agree, David, that's very comprehensive. And one of the things I found very useful is that Nuvasive have this online app where you can discuss your first cases and people can comment on them. And I think that's really great for people who are starting off, that be able to discuss with people who have a bit more experience, and you can critique each other in a very constructive way. Now, have you got any top tips of how to help colleagues who want to start off on this journey?
Yeah, thanks, Jake. Well, David covers it very comprehensively and very well, actually. In addition to that, though, what I would say is really get the multidisciplinary team involved. Get your vascular surgeons involved straight away. I've got a very dynamic vascular surgical team. I let them know what I was intending. The Nuvasive courses actually do have certain sessions where there are vascular surgeons who attend, so there is capacity to get them integrated from start. The other thing is to bear in mind the most complex part of X360 isn't actually the scalpel, it isn't actually the implant in the cage, it's the procedure, it's the patient flow. So get your theatre team involved and engage in the process from a very early stage also. It's no point in going through a year or 6 months of training and then have to start again the learning curve and the journey with your team. Get them involved from the start.
And I'd echo what you said, because I think it's really important when people come on the training courses that they need to have a case already set up, because as you said, there's no point in doing a training course and then waiting another year where you've forgotten everything. So I personally would say, have you got a case that you've got in mind? And if you have, then you should come on the training course and get that case done as soon as possible. I think it's really key. And I can't emphasize enough how important it is to visit other surgeons. And when I have surgeons visiting me or vice versa, I'm always learning something. You always get one or two little tips and tricks that you haven't thought about, that someone has actually put in their practice. And I've taken so many times I've changed my practice by visiting other surgeons. You know, this has been really interesting discussion, and we need to wrap it up. So I'm going to ask you both one question, which is, if you can give me one sentence why you think X360 should be in the surgeon's armamentarium. David.
I think with performing a fusion at the L5S1 in the lateral position, I have a much better control over the reduction and the patient has a quicker recovery.
X360 to me is a truly minimally invasive technique which allows powerful restoration of sagittal balance in lower doses, at the same time powerful indirect decompression, which ultimately, and what we're all here for, is to achieve better outcomes for the patient in terms of improvement of pain and recovery.
Excellent. That's a pretty good short sentence as well. Well, I'd just like to end by saying thank you both of you, Nav and David, for your pearls of wisdom, your insights. I hope people who are listening to this webinar find this useful, and hopefully we've inspired you in considering to take the X360 concept into your practice, where we hope it will improve your patient outcomes. And it's apparent in the last 20 minutes that there are some real interesting areas which we'll be discussing in the future webinars in this Nuvasive series. If you are interested, do contact your Nuvasive rep. He can give you more information about the training courses and all the other online modules that are out there. Thank you very much. Goodbye.